So good morning, everyone. We might get started. Welcome to everybody online and welcome to everybody here in the room. Just as we get started, I'd like to acknowledge that we're on the lands of the Turrbal and Yagara peoples and pay our respects to their elders past, present and future. And of course, pay our respects and a particular welcome to our Indigenous colleagues who are with us today, especially Moana. So we've got a great presentation, or actually a couple of presentations today. One on a project called Indicare, which is about diabetes, type 2 diabetes, and another one about intergenerational health in the Northern Territory, or the iHint project. We've got two of our very well-respected and popular academics speaking on those two topics this morning. So Chris Sexton is one of them. He's a biostatistician whose work focuses on the social determinants of oral disease and equitable access to dental health care. He's an expert in quantitative methods and analysis and has collaborated widely across multiple health disciplines. And Chris, you're going to be talking about the Indicare project to start with.
Yeah, right, great. Thank you very much, Anthony.
Welcome. And just before I let you loose, we'll also welcome Tamina.
Sorry.
That's right. Tamina Begum's a research fellow here. She's particularly interested in quality improvement in healthcare in non-communicable diseases, prevention, health information systems, and improving access to health services for refugee and underprivileged populations. So, welcome, Tamina. All right, Chris, over to you.
Thank you very much. I'm just going to set up quickly and share my screen and make sure that that's all established before I really commence. Sec. Okay, great. That seems to be coming through. Okay, great. Slides aren't showing there, and I wrote all that information. Good morning. My name is Christopher Sexton. I'm a non-Indigenous man presenting on another diabetes care, also called Indicare. I'm a biostatistician, and so I will be presenting some results. Oh, well, not results. I will be presenting the project that I've been working on. I'll also be talking about some of the benefits and lessons learned from a data linkage study, which is what this project is looking at. I also want to start off right at the very beginning and just sort of mention, I do apologise that I will have to take off halfway through our presentations today. I'm supposed to be looking after my 4-month-old baby who is currently at home. Not by himself.
By himself?
Things to get ahead of things, not by himself. And so I need to get home to get some sleep straight away after this. So I will be presenting, and then we'll have a brief section there to have it answer any questions if there are any. I would like to acknowledge the traditional owners of the land. Is that not coming through?
No. Sorry, you'll be stuck with moving to
Sorry,
slide.
everyone. It's not cycling through. Try again. Oh, there we go. That should be working now. Oh, great. Thank you. Okay, sorry, apologies for that. So I'd like to acknowledge the traditional owners of the land, the Yagara and Turrbal people. I acknowledge their custodianship of the lands on which we meet. I wish to pay respects to the ancestors and their descendants and continue cultural and spiritual connections to the country that we work on. And I recognise their valuable contributions to Australian and global society. I would also like to acknowledge my Indigenous colleagues that are with us in the room today and also joining us online as well. Some further acknowledgements that I would also like to, for this project specifically, acknowledge the Inala Community Jury for Aboriginal and Torres Strait Islander Health Research for their oversight and guidance on this project. I also wish to say a big thank you to the Inala Centre of Excellence patients and staff for contributing to this study. And also I'd like to acknowledge the entire UQ Poche and Queensland Health Inala Centre of Excellence investigator team that are up on the board at the moment. The research that I'm presenting was funded by the MRFF Indigenous Health Research Fund as well. And I'd like to acknowledge that. So our study investigated the management of type 2 diabetes in Aboriginal and Torres Strait Islanders. The Aboriginal and Torres Strait Islander peoples are almost 3 times as likely to have type 2 diabetes than non-Indigenous Australians, and the proportion with type 2 diabetes exponentially increases with age. The average age of diabetes onset is reported to be much younger among Aboriginal peoples than non-Indigenous peoples. Pardon? Oh, it's not working. Oh, sorry. Maybe, oh, sorry, it's just not coming through again. Sorry, Kate, I might be able to swap over to your computer instead. I've tried this a couple of times and it's, sorry about that for everyone online and in the room. Yeah.
No.
Yes.
Yes.
Yeah, I'm happy to swap if that's available.
You want me to
Just up to where. Okay, thank you. There we go. That's better. Okay, cool. So I was just saying that the average age of type 2 diabetes onset is reported to be much younger among Aboriginal peoples than non-Indigenous Australians. Research on trends, determinants, management, and burden of diabetes and burden of type 2 diabetes in southeast Queensland urban Aboriginal populations is nearly non-existent. With that information about the burden of diabetes, I'm going to pass over to Federica, who's going to describe the process of establishing a relationship with our colleagues in Inala.
Thank you, Chris. And for those that do not know me, I think there are a few people online that don't know me. I'm also a biostatistician. I work with Chris and Tamina. So I just wanted to talk over a couple of slides that describes the process of engagement with Inala and how we came about this research project. So we met for the first time, UQ Poche meeting. I was lucky enough to be part of the group that attended to the first meeting with Inala in May 10 in 2021. On the same day, also it was the 2 organizations signed a memorandum of understanding. We started working with them officially. We had a discussion on that day, and it became evident that one of the priority of the community was type 2 diabetes, and just evaluate and check how the community was doing in regard to that management. So the Indicare project was conceived on the same day, and is the first collaborative project resulting from the partnership between Poche and Inala. After this 1-hour meeting that we had in May, the project was further defined and discussed with the members at Inala, in particular Jeff and Prava, 2 clinicians that work there. And it was also endorsed by the Inala community jury for Aboriginal and Torres Strait Islander. The next slide describes more in detail the process to engage with Inala to do research. So step 1 involves a preliminary consultation that is usually done with the director of research at Inala, and it could be done with other researchers as well. And after that, the director of research will invite the researchers, if they approve the research, to apply for more detailed discussions with the research committee. And this involves basically writing a research proposal, a short research proposal that goes to the research committee. The third step, which is the one I'm going to talk a bit more, is the written application and also discussion with the community jury. So the community jury comprises 12 to 14 local Aboriginal and Torres Strait Islander individuals who have the opportunity to literally interrogate researchers who want to undertake research within the Inala Indigenous community. And the functions that a community juries are to assess new health research proposals and review whether they are responsive to local priorities and respectful of local community cultural processes and protocols, review existing and ongoing health research projects to ensure that they are still remaining responsive to these processes, answer the questions that all the researchers have when they meet the community, which is, do you support my research? And if not, what can I do to improve it? And the jury, I heard, is very responsive to that. They never say absolutely not to anyone, but often they do ask you to think about your research again, and they come back with a new proposal that include the comments, that the feedbacks that have been given. They also provide advice, support, and recommendation in a timely fashion to research and partner research institution, and they also assist with the further steps of translation and implementations. So we met with the jury in October 2021. It's been a long time, and James, Wood, and I traveled to Inala. I was literally shaking in the car. I was super nervous. But the meeting was absolutely fantastic. I managed to relax my nerves within 5 minutes, and the jury was very interactive. There were a few people that had diabetes themselves, and they shared their story. One of them in particular, they struggled to remember to take all the medications, and good days and bad days. And from the discussions that we had with the jury, it became quite obvious that the priority of those people in the room were two. One of them was what are the characteristics? How do we manage diabetes optimally? How are we on top of that management? And mostly it was, how do we keep our people away from hospitals? So that was what mattered to them the most. So we went back and we designed a study research proposal for submission to the MRFF based on the recommendation of the jury. So very much around management and optimal management, and also characteristics of people that don't get hospitalized. So yeah, and back to you, Chris.
Thank you. From there is when I started working on this project as well. So that's some part that I could actually talk about how that relationship further developed. So during this period when I started working with Jeff and Prabha at Inala, I was working as consulting with them to guide them through the preparation of the Inala content data before the data linkage occurred. I worked predominantly with Jeff and Prabha to construct a data dictionary and identify variables from extraction from their annual health check data and the annual diabetes check and best practice. It was a pleasure to work with these health and research professionals on this project. And I would like to also mention specifically that we had multiple trips to Inala that included many shared coffees and lunches at the Vietnamese restaurant across the road, which so happened to be Jeff's favourite and also one of my favourite types of food as well. Now, I've got a slightly impossible task to try to get across for this next 10 minutes or so. I'm going to be talking largely about data frames, data linkage, and what can go wrong or what can occur during those processes, some of the benefits of it. For a reason I'll go on to later, I'm not going to be sharing results at the moment for IndyCare. So I do have a bit of an impossible task that I have to talk about data and keep it interesting. For those who aren't a biostatistician and who aren't interested in data frames, anytime that I'm talking generically about data, I'm going to put a little picture of a puppy up there to keep you interested and focused on my presentation for a bit and awake with me. For those who then when it is about indie care, the puppies should disappear. Okay. So that's, if you just want to follow along that way, that's to keep you engaged with this process. I will warn you, they are very cute, and I'll let you try to guess which ones belong to me. So why data linkage? So firstly, they offer an opportunity to explore unique relationships. We know that electronic data is being collated by multiple sources, and it would be wise to be able to use that data thoughtfully. It can also be beneficial to do a data linkage project because it can lead to improved measurement that can lead to better precision in your estimates or in your analyses. I'm going to go through those processes, each of those points in a bit more detail and how they related to IndyCare specifically. These here were the aims for IndyCare, and I realise I've got a typo on there and I do apologise. So IndyCare aimed to identify treatment that optimises the management of type 2 diabetes in Aboriginal and Torres Strait Islander people in an urban setting. To achieve this aim, we wanted to estimate the trends in incidence and prevalence of type 2 diabetes. We wanted to investigate the management, including pharmacotherapy and factors that are associated with optimal diabetes management. And we wanted to explore the management of type 2 diabetes and then the determinants of a lower risk of hospitalisation that was identified as being important by the Inala community jury. Now, the ideal study, from a study design perspective, the ideal study for this situation would be a longitudinal cohort study. However, with type 2 diabetes having an estimated prevalence of 7% in an Aboriginal and Torres Strait Islander population, the number of people required for that, the sample size required for that is actually quite prohibitive. And so therefore, prohibitive, as well as the follow-up time to actually follow that cohort progressively over time and watch what outcomes actually occurred would also make it too expensive and basically occur over a long period of time. So this is where a data linkage study is actually beneficial in that case, because we're able to explore these unique situations that can occur, or these unique relationships further. We also know that electronic data is collated by multiple sources. I'm going to go through and talk about some of those sources, specifically for IndyCare. There are some QR codes if you want to be able to look at those sources themselves as well. So to give you an idea as to what other data is available if you're interested in doing a project that's similar to this. So first of all, we gathered clinical data that was sourced from the Southern Queensland Centre of Excellence in Aboriginal and Torres Strait Islander Primary Health, or the Inala COE Centre of Excellence. Data from Inala was broken down into these groups. I'll be talking about that a bit further later on, but these data is often collected through annual health checks and annual diabetes checks. The data was then complemented with pathology data from best practice. I would also, at this point, like to acknowledge and thank the Inala COE patients and staff for contributing to the study, as well as the Inala community jury for Aboriginal and Torres Strait Islander health research as well, for their oversight and guidance.
Chris, sorry to interrupt. Someone just said there's a bit of an echo coming through. Is the microphone on the laptop off?
I'll have a look.
Someone else said that.
The microphone is off and the sound is off here.
Okay, that should be okay.
Uh,
So we saw the message from people online about the echo, so we're just trying to fix it up.
Yeah, there's a couple of people that are saying there's no echo at the moment for that. Thank you very much for that. The clinical data was joined with the data that we applied through by application to AIHW. AIHW provided access to medications that were used for the management of diabetes through the PBS, or Pharmaceutical Benefit Scheme or Schedule data set, and that's available through application to AIHW. Data was collected for individual patients about dates, prescription and receipt of their diabetes medications, and they were broken down into novel diabetes medications, traditional diabetes medications, and then other medications to manage diabetes as well. Additional data describing patient mortality was also acquired for the National Death Index, and they were linked to our data too. This data was all joined from information from Queensland Health Data. So this was accessed through the Queensland Statistical Services branch. It was on hospital admitted patient data collection, non-admitted patient emergency department care database. And this data was used to investigate the management of type 2 diabetes that is associated with lower risk of preventable hospitalisations. And this aim was suggested by the Inala Community Jury for Aboriginal and Torres Strait Islander Health. As discussed, the ideal study design that we would want to use would be a longitudinal study design. The diagram on the left-hand side sort of explains that type of study design. You've got a population of people, a cohort that we're interested in, that's people with type 2 diabetes. We then investigate the relationship between the predictors and the outcome variables. In this little example, we have a predictor that's our management type. We would then measure the rates of whether the guidelines for management were met or not for those different predictor groups to investigate how well that management type was leading to improved type 2 diabetes management. With that in mind, we then investigated multiple different outcome measures for diabetes. So we investigated weight loss for those who are overweight, blood glucose levels and their management, blood pressure, and kidney function. We also investigated the Royal Australian College of General Practitioners guidelines for the management of type 2 diabetes, and they're considered a guideline that was met, a guideline that was not met, and they included measures for body mass index, blood glucose levels, blood pressure, and kidney function as well. Additional outcomes were preventing hospitalisations. We looked at the factors on the right-hand side, the dot points here, and considered to investigate factors that were associated with hospitalisations. Oh, and yeah, okay, cool. And then we also looked at different subsets of predictive variables. So whether they would, and we looked at factors associated with demographics, health and lifestyle factors, life stresses and mental health, community social and economic well-being, and other known health problems, as well as then the type 2 diabetes management that included diet control, blood monitoring as well, monitoring, and also pharmaceutical management as well. Now, as mentioned, it is possible to have improved measurement, which is a real benefit for data linkage. So it is possible that data linkage may result in improved measurement of data. So data linkage can increase the sample size with data complementing or supplementing existing data. Examples of that for Indicare was medication prescription and supply date was gathered from PBS or AIHW, and this supplemented clinical measures of those prescriptions instead, because we know then definitely that it has to be it is collated in that data set. Pathology data was used to identify patients with blood glucose that was greater than 6.5%, and this then complemented other clinical measures of type 2 diabetes to really improve that precision of measures through that. There were a number of lessons that we learned throughout our data linkage studies. So one of the things that we learned about it was the amount of time it takes when dealing with large institutions or multiple different institutions and having to come to multiple agreements. So down the bottom, we've got some of the types of agreements that you will need with these institutions, whether it be ethics agreements, other governance factors, as well as there's some with AIHW that were very specific for them as well. Now, across the years, doing that thing again. Across the years, some of these agreements some of these agreements can work in parallel. Others have to work in series and cannot start before one of the previous agreements has been met. And with the more institutions and the more agreements that you have, the more requirements there are to meet them. And it is the researcher's responsibility to be able to navigate that pathway throughout there. I do have a bit more about that later on, but it is really on the researchers to be aware of what data is available and how to actually follow and navigate that system. I think it's just the animations. Okay. Another lesson that we learned from the data linkage process is that the data that you're using isn't gathered for research purposes. It is gathered for administration or for other purposes. And so we're trying to use it against what its original purpose was used for. And with that in mind, the researchers then lack control of that data collection quality. It can result in your data being messy and not collected at routine frequencies. It can be measured in different formats that may require extensive cleaning. And over long periods of time, it might even result in that the measurement format can change as well, or that guidelines, for example, might change as well or be updated. The solutions throughout this would be, we would recommend to keep your processes simple and appropriate research questions, collaborate with your stakeholders to identify data sources and clean where possible, and be mindful of that data quality, limitations, and over-interpretation of any results that you do find. You can also result in really complicated data structures. On the left-hand side, this is the ideal situation that you could have if in a data linkage study. If we're trying to join data A with data B, what you want to have is a key, and that key correctly identifies each individual and it identifies A and B. And when we merge them together, we should end up with a nice one-to-one relationship, so that way that each variable has a merge that matches with it. That's the ideal situation. What we found, though, in reality, is what you can have is actually a situation where you've got two keys. For example, we've got an ID and a date in this situation. And what can happen is when you go to join and merge those, you end up with what is called a very sparse data set. And that data set can be what is wide. It can be wide across and long down the page. For IndyCare, the merging of pathology and PBS data resulted in a wide and long sparse data set. A lot of the problems that we saw was caused by pathology. It was particularly messy due to the multiple measures of outcome variables with different and unspecified units. Another cause of wide and sparse data set was also the PBS data set as well, with people getting multiple medications, multiple times, all that not corresponding necessarily to the dates at which their appointment was or any other dates that corresponded with the data. Our recommended solution for this was we really relied on our clinical collaboration to navigate where these variables and could be combined where possible. We also used a date window, so made that date over the last month. Did they have this situation? Have they ever been prescribed this medication? To be able to then join them up by making that date window wider. So data access requirements, proper data governance is required, and it does take time. Each agency has their requirements for data access for research, and it's their responsibility to navigate through these systems. The process can be challenging, opaque, and unique for each agency. Researchers need to collaborate and discuss their needs with the data custodians. The governance is important as the data that was not collected for research purposes, and so you need to be aware of any limitations that may be available, that might occur when trying to access that data. For an example of this was for IndyCare, it required us to use the Sure environment, which is a curated environment that limits access of the data, and it limits withdrawing analysis outputs. Connecting and analysing data within this environment has taken time, as well as another situation that has occurred was with dealing with the AIHW. There was a large staff turnover while we were trying to collate our data, and having to catch the staff up to where we were up to with our data access took us back a couple of bit each time, as well as there was flexibility with accessing their data with multiple different data formats available. And we would often get recommended to be tried for it was called the Hub at one point, but it was a national data set, but it wouldn't have been appropriate for us because we were looking at Aboriginal and Torres Strait Islander data specifically. So the current status of Indicare. Results are currently being prepared to be shared with the Inala community jury for Aboriginal and Torres Strait Islander health research during November this year. We have investigated the trends in type 2 diabetes management with the predictors in those sets. Up on this board in the orange part is the statistical methods that we have been using. I'm not going to read them. They're there if you would like to have a read of them. But basically, we're using very multivariable models to investigate the relationship between these factors. There have been difficulties in modelling the relationship between diabetes management and medications due to the avalanche of data that is available. We are exploring the management of type 2 diabetes and determinants of lower risk of hospitalisation. And yet again, this is the method that we're planning on using for that. It will be a survival analysis. Going forward into 2026, we're currently going to be discussing with the Inala community jury and listening to their advice to guide the interpretation and translation of the findings from Indicare and put that into clinical practice. We also have planned a workshop for clinicians, Inala community and stakeholders that will occur in 2026, where results and guidance on the management of type 2 diabetes will be communicated and disseminated to reduce the burden of diabetes in this community. Thank you very much for your time. Finally, I would also yet again like to acknowledge everyone that's up on the board, and thank you very much for bearing with me through that presentation and the issues that we had. Thank you.
Thanks, Chris. You did very well managing those technical issues. Does anyone have any questions for Chris? Anyone online? I might go first. So while you were talking, Chris, I started thinking about the potential for confounding. So that's variables that are related to both getting treatment at a point in time and the outcome. Do you, I presume, did you go through a process to figure out what some of those confounders might be?
Yeah, so we did spend some time at the beginning trying to map them across and really spent time. So we know that we know we've got time incorporated in our measurements, so we're able to quickly isolate which one comes before and which one comes after.
Yeah.
Whereas for confounding, we're able to then spend some time actually indicating which variables could be interrelated between the exposure and the outcome.
Yeah.
The issue does become tricky if there are any feedbacks as time starts incorporating into it as well. Yeah. We did spend some time looking at that. Yeah. So right. Your answer is yes, we did think about confounding. We're also aware of the limitations of our results, and yet again, that overinterpretation of potential bias that can occur due to confounding.
Yeah, great. Okay. Any other questions?
One's for your dogs.
Yeah.
I snuck in twice. So there's the one where the two golden retrievers. Oh, it's gone now. There's the two golden retrievers, and I'll happily share these by email if anyone does need to see them again. There's the two golden retrievers, and there was one that was a baby portrait when he was young.
Yeah. Any questions from people online? I might just ask one more if I can, before you disappear.
Yes.
So I know you indicated that the jury and the clinicians at Inala will think about the results and how to interpret them and how to use them to improve clinical practice. That's the ultimate goal. Can you give us a sense of, in these types of studies, how that might work? So say you demonstrate that, I don't know, I'm obviously making this up, but older men are more likely to be hospitalised. Can you give us a sense of, how a clinician might think about what to do with that?
Look, I'm going to be really careful with my wording through here because I don't want to presuppose situations that may or may not occur with the data. But I suppose some of the things that we may potentially be finding is the management could be changed earlier. Perhaps it might be the changing of medications. Perhaps it's also the changing to lifestyle or dietary factors that may actually be able to be incorporated earlier at that management of diabetes that may then lead to better prevention of hospitalizations.
Yeah.
That would be the ideal situation, and that's what we're ultimately aiming trying to find out.
Yeah. Right.
Yeah, cool. Thank you. Thank you very much, and I'm really sorry that I need to go, but thank you everyone for your attention. Thank you.
Okay, so we're going to move on to Tamina. You.
Thank you, Anthony, and thank you, Chris, and good morning, everyone. So my study title is Transgenerational Association between Grandmom's Diabetes in Pregnancy with the Grandchildren Birth Weight. So I will be using a study finding from a data linkage study that calls the IHINT study, that is the Intergenerational Health in Northern Territory dataset. So before starting the presentation, I would like to acknowledge traditional owner of the land and water where we are meeting today. For me is Yagara and Turrbal people, and also like to acknowledge the traditional owner of the land on which you are dialing today, if it is different than mine. And I also like to acknowledge my Indigenous colleague here, also my elder in residence, Auntie Mary is not here today though, but for sharing your the guidance and all continuous the guidance and your lived experience with us. And it's further acknowledgement that I should mention here before I'm going to my presentation. First of all, the generous receipt grant research funding that I received from the Poche Center that helped me to do this analysis so far. And then most importantly, Aboriginal and Torres Strait Islander Advisory Group of the Diabetes Across the Life Course and Northern Australia Partnership Project, as because for their the generous consent and guidance that was possible, that the data been shared with us and that we can access the data, and then my approval with the ethics as an amendment, and also allowing us to use this IHINT study. And for that reason, I would also like to acknowledge the study investigator of the IHINT study, and also to acknowledge all the moms and babs for whom this data we have been using, though this data has not been collected for the research purpose, but sharing their health data for research help us to using this unique source of data set. So, and moving forward, we do have some finding regarding the Diabetes Across Partnership Research Project and Community Engagement, as because Federica Bargi was directly involved in this partnership, and she was the CI of this partnership project. I would pass this slide to be presented by Federica.
Thank you, Tamina. Yeah, I just want to talk a little bit more about the Diabetes Across the Life course, the Northern Australian Partnership, which gives the overarching governance to our study and analysis as well. So the partnership is led by a team at the Bentley School of Health Research, and we support an involvement from a range of health services and organizations. Includes researchers, policymakers, health service providers, and consumers. Notably, 50% of the members are Aboriginal and Torres Strait Islanders, and the partnership starting in 2011, including communities from the Northern Territory only, and over time evolved with further funding to include community in Far North Queensland as well. So the aim of the partnership is to improve the health and well-being of people in the NT and Far North Queensland regions by working together to grow and share knowledge about diabetes, strengthen systems of care and services for people with diabetes, and develop prevention strategies. In particular, recognizing the intergenerational cycle of diabetes and the high burden of diabetes among Aboriginal and Torres Strait Islander people, the partnership current effort particularly focuses on women with diabetes in pregnancy and their babies, young people with type 2 diabetes, and diabetes prevention in children. Working with partnerships and having project embedding into these partnerships is essential to translating research outcomes into practice and achieving sustainable health outcomes. So So far, the impact of the partnership has been remarkable. The partnership has directly influenced national and state and territory policy, including the National Diabetes Strategy. And results have been translated into clinical guidelines, ensuring that clinicians are aware of factors related to intergenerational diabetes, especially in the remote context. So the AINT study, of which Tamina is going to discuss the results of, one of the aim of the AINT is nested within the partnership, and it contributes, is part of the, it's part of the partnership theme that aims at developing knowledge, but then it will also, the knowledge generated from AINT will also be translated and inform guidelines and implementation. So one of the requirements of the partnership is a discussion with the Aboriginal and Torres Strait Islander Advisory Group for the partnership. Every research ideas of projects involved within the partnership need to be discussed with this Indigenous group. The analysis that Tamina led were already part of the AIM studies, but because it's led by an external researcher, then we still needed the approval from the advisory group. That was obtained, we obtained a letter of approval, and further to this approval as well, one of the requirements of the partnership is for researchers that are not based in Darwin to actually spend some time in Darwin, get to know the community, sit down with the advisory group and shape the analysis of the study and also discuss results and go from there. So Tamina and I went over to beautiful Larrakia country in April this year. We spent a few days talking to the advisory group and also talking to the lead researcher of AINT over there is Matthew Hare, which I believe is online. Matthew spent 3 years completing a PhD project on AINT. Yeah, I think that's all from me.
Thank you, Federica. So on moving forwards, what I'm going to do, I will present study findings. So, but I will follow like the traditional method of scientific presentation to give some bit of like knowledge about what we already know about this research topic, what's the research gap, and then what prompted us to identify this research aim, and what analytic approach, and then some major finding for our research. So diabetes in pregnancy, here we will be combining both pre-existing diabetes and the diabetes that develop for the first time during pregnancy. And this diabetes in pregnancy across the literature was referred to as a two-edged sword. That means it has a both adverse health consequence both for moms and babs. And it's been evident that diabetes in pregnancy associated with the altered weight growth. That means the babs can be high or low birth weight, and this effect can long lasting for both for moms and babs post pregnancy that lead to a lot of cardiometabolic complication that include like the persistence of the diabetes and also like the high BMI or associated complication like the kidney disease or stroke and so on. So this intergenerational impact of diabetes in pregnancy is of multifactorial origin. The one thing is the genetic inheritance that we cannot control, but the things that we control, there's other environmental factors. So these are the three main bullet points that I put it here. That's the underlying body physiology that gone through when mom's exposed to the high blood glucose level during her pregnancy. One of them is the epigenetic modification. This is not the genetic inheritance, like some germ cell memory persists and that pass through the daughter offspring, and then she can develop the diabetes in her own pregnancy, and some metabolic programming can happen with the fetus in utero. For example, there would be some insulin resistance or beta cell dysfunction that control our blood glucose level within the body, that can hamper, and baby can be like the high or low birth weight. And some other like the behavioral socio-cultural factor, for example, dietary habit, physical activity level, or the access to healthcare that might be clustered within the family, that can transfer intergenerationally across them. So what we identify, so as I said, that the association between two generations has already been established across some of the studies, but this intergenerational association across 3 generations evidence is really scarce, and particularly for the Aboriginal and Torres Strait Islander population. So in our extensive literature review, what we found like the closest 3 generational association that's been evident from 2 of the studies from the England and China, where they have found there was some positive association between the grandmaternal diabetes in pregnancy. Is not necessarily diabetes in pregnancy, that was the diabetic history with the higher birth weight and early childhood adiposity trajectory in grandchildren. So these 2 studies had some methodological limitation that prompted us to design this study from the IHIND study. So that means the grandparental diabetic history that been collected, that was from the recall history of mom. And also they use only the binary outcome of the grandchildren birth weight. And they didn't consider the causal pathway like that maternal DIP can be in between from the grandmom's DIP to the grandchild birth weight. So considering that, so we have aimed to analyze to understand what's the intergenerational effect of DIP with 2 specific objectives. First, we have to look on our study cohort, what was the association between the first generation diabetes to second generation diabetes in pregnancy. What is the transgenerational association? Means the 3 generation association from grandmom diabetes to grandchild diabetes, and how much of this effect is being mediated through the second generation diabetes in pregnancy. So in doing so, we have used the IHIND study. So the little bit short snap of IHIND study here. So this is a like the 3 generation study cohort, large retrospective study where it include like more than 100,000 birth. Among them, 36% was like the Aboriginal moms. So the study basically intend to identify the diabetic epidemic over the 3 decades, the trend of that, and how this impact the health of moms and babs, linking these 3 data sources: birth data, hospital inpatient data, and primary healthcare data. And from the IHIND study, so 2 of the articles been published. So first author was Matthew here. So that's pretty much linked with our study, the third study that we are going to do. The first study, they have looked at the trend of this diabetes in pregnancy and the birth weight status, where they found like the 1 in 5 Aboriginal women in Northern Territory was diagnosed with DIP in 2016. And while looking on the 3-decade trends, we found that small for gestational age remained stable, but the large for gestational age become double over the period. Here to mention that we only analyzed here the Aboriginal mom, as because in NT, like that more than 96% of moms from the Aboriginal background, so they just only consider Aboriginal mom in their study. So for the second study that's published in Diabetologia, I guess, that's look on the post-pregnancy complication. So in this study, over the 12 years of median follow-up period, so they found that more than 1 in 10 women, like the Aboriginal women in this study cohort, developed end-stage kidney disease, those who had the diabetes in pregnancy. So compared to the women who did not have diabetes in pregnancy, the chance of developing end-stage kidney disease was faster for the mom who had the diabetes in pregnancy. If we further break down into the proportion into the gestational diabetes versus the pre-existing diabetes, that was higher for the pre-existing diabetes. So from with this statistics from our studies, so we have used only the Northern Territory prenatal data collection as a data source. Like we just use the 3-generation birth data to link them up, and then that goes from 1st January 1986 to 31st December 2016. So our study participants were Aboriginal and Torres Strait Islander grandmoms with their female daughters and grandchildren. So here in grandmother generation, I will be calling them as a generation 0. So we had about 2,696 grandmoms. From them, we have moms who are the generation 1, G1, 3,191. And from there, we had like the generation 2, that is our grandchildren, that was 5,487. So exclusion criteria includes the multiple pregnancy, gestational weeks less than 20 weeks, and so if the baby born sleeping, private hospital births, and the insufficient linkage key that we could not link the grandmoms to like the 3-generation. And for statistical methods, so we report the descriptive statistics to explain the population characteristics. We use the multiple regression method where we have adjusted multiple birth. As you have seen the previous slides, that we had number of child more than the number of mothers. So we use the generalized estimated equation model to adjust this clustering effect in our method. So in our mediation analysis, we further decompose the total effect into direct and indirect effect. By the total effect, I mean that the effect being accounted for by the perinatal confounder and other mediating effect of first generation DIP. So direct effect is the one, the grandmom DIP directly associated with the grandchild birth weight, not mediated through the first generation DIP. Indirect effect is how much of this effect in between grandmom diabetes and pregnancy to grandchild birth weight is indirectly mediated through the first generation maternal DIP. So here that in our mediation analysis, so our like the exposure variable was diabetes in pregnancy for grandmoms, a binary variable. Compared to the outcome variable, we have used both continuous and categorical variable as measured birth weight in gram, gestational age and 6 standardized G score, large for gestational weight, that means more than 90th percentile of birth weight, and small for gestational age, that means less than 10th percentile of birth weight. And that as an intermediary pathway in the causal pathway, we consider the mom's DIP as a mediator here. So for the descriptive finding, we have found like in the mother generation of those 5,000 over the 5,000 grandchildren, diabetes in pregnancy compared to the grandmother generation about 3% higher, and then having the birth of baby less than 37 weeks was a little bit higher in the mom's generation compared to grandmom generation, but the small for gestational is babies reduced a little bit from the grandmom's generation. So the first slide from our regression finding from the association between the grandmom's diabetes in pregnancy with the like the first generation diabetes in pregnancy, we have run different models. Started with the crude risk, and then we have the adjusted model 1. We have added all the perinatal confounders, and then model 2 we have added mom's birth weight. We consider having the diabetes in pregnancy, mom's birth weight could be the intermediary variable. So to adjust this one, the model 2 would be accounting for. And then for the BMI data, pre-existing BMI for moms, we had like the sample, like the only available samples in 1372. For that reason, the top 2 relative risks been showing for the sensitivity analysis restricted to the sample for 1372, where the model 3 added the pre-pregnancy BMI in the model. So here the relative risk being presented with the 95% confidence interval. If it is outside the 1, the reference point, that means it's the significant. So presenting this like that overall finding is that compared to grandmoms without diabetes in pregnancy, grandmom having the diabetes in pregnancy had 2 times more likelihood to have a daughter who would develop diabetes in her own pregnancy. When we added maternal birth weight and pre-pregnancy BMI in the model, we didn't see the altered association, the positive association or direction of association persisted. So then moving forward, our mediation analysis, where we consider the grandchild birth weight in continuous scale as measured gram. So here the direct pathway, like the direct effect of grandmom diabetes in pregnancy to contributing to grandchild birth weight is shown to be 72 gram higher birth weight compared to the grandmom who did not have the diabetes pregnancy, and is not mediated through the intermediary pathway of the moms, first generation moms having the diabetes in pregnancy. And then when we consider the mediating effect of the first generation mom's DIP in pregnancy, diabetes in pregnancy, that shows that 36 gram higher birth weight in grandchildren, that's mediated through the first generation DIP. And then of this, like the mediating effect of the mom's DIP was 36% on total effect of 112 gram higher grandchildren birth weight. And moving forwards, we have also looked for the gestational age and sex standardized G score, where we have moved on the within the normal distribution, the mean zero standard deviation of 1. What could be the effect? We have found the similar strength of association between like the G0 DIP to G2 DIP with about like that 0.26 standard unit higher grandchildren birth weight in the total effect of them, 36% being mediated through the first generation diabetes in pregnancy. So when we consider the birth weight of grandchildren in a categorical scale of binary outcome of LGA, so what we have found, there is like the similar positive association, like about 48% higher chance of having the infants higher birth weight of grandmom having diabetes in pregnancy compared to grandmoms not having DIP. And then there's a similar association for indirect effect. And here the contribution of mom's DIP is about 53% being mediated in this relationship. And then when we goes to the small for gestational age, we didn't find like the similar positive association. So we found there is this association between weak and non-significant. When we consider small for gestational age as an outcome variable in exposure to grandmom's DIP. So having said that, so our like the summary finding is that grandmom's diabetes in pregnancy contributed to higher grandchildren birth weight. That has some direct effect and also been mediated through the maternal DIP. And so to break this transgenerational cycle of diabetes in pregnancy impact on moms and babs' health, we feel like that culturally tailored preconception and antenatal care intervention are much essential in this context. So these are the references that we have used in this presentation, and also thanks from the team that's actively been involved in this analysis and preparing this presentation. Thank you for your patience.
Great, thanks, Tamina. Anyone have any questions for Tamina? When I looked at your result, and I think can you just get back to your results slide, Tamina? It looked to me like there was still a fairly sizable proportion of women where the relationship between grandmother and grandchild wasn't particularly mediated. So, right? Or I misinterpret that.
Better skip this presentation. Which one is it? So I leave it.
Is it 22?
Yeah, that one, I think.
What should I do?
No, you have to read it fast.
Okay, so.
Yeah, you mean
Anyway,
the
doesn't matter. I'll ask the question another one.
What is the question, Anthony?
So were you surprised? Did the rate at which the relationship between grandmother and grandchild was mediated by the mother?
Yeah.
Were you surprised that that finding, or is it about what you thought?
No, that's the expected finding. Yes, because so like definitely some is the direct association between the moms to grandchildren. This is the closest proximity of association. But as because in my background information, I explained like the epigenetic mechanism, and then these are the metabolic programming. So that's that's why I put this slide here. So that cause like when moms exposed to like moms as a baby exposed to high blood glucose level, so that causes some DNA methylation in her own like the germ cell. That is called the metabolic memory that persists, and in response to like the exposure, like the excessive stress, like other environmental factor, for example, dietary and lifestyle factors, that can like they accentuated the effect, and that can cause the overexpression of this germ cell line, and the mom can develop the gestational diabetes, even she was not diabetes before. But over the time, before she get pregnant, she had the diabetes, that definitely she would be starting the pregnancy as a pre-existing diabetes. And apart from the diabetes, this intergenerational effect also transmitted with other comorbidity, could be the high BMI, and then like also smoking also been identified, and having the hypertensive mother that can contribute to having this overexpression of the germline, and then having the gestational diabetes maybe for the first time in the pregnancy as well. So that's the beauty of having the mediation analysis, I believe. So that's that we know like independent when we use the maternal DAP as a confounding model, that will show us the independent contribution of moms and grandmoms on the grandchild birth weight. But what proportion of them, like this 36% mediated through the maternal diabetes and pregnancy, that we can only like the add on the answer that already been available to us.
Thank you. Any other questions?
I guess Tamina, is there like a plan to have some discussions with clinicians about how these findings could be incorporated into clinical practice, I guess with the dissemination of the knowledge?
Yes, in terms of dissemination of knowledge, so this is the preliminary results we'll be sharing with our like Aboriginal advisory group over there to understand what's the result mean to them, how to better translate this finding in different contexts, like the community perspective and clinician perspective. And then also we do have a like the endocrinologist in our team, like the Matthew here. So
And the partnership.
and the partnership as well. So that's the better like the so definitely that's in the plan.
Come.
All right. Well, if there's no other questions, we might leave it there. Thank you, Tamina. That was really interesting. So thanks for sharing that with us today. And thank you, everybody online, for joining us this morning. And we'll see you next time.
Thank you.
Thanks.